Good morning. My name is Sue Grinnell, and I'm with the Public Health Institute, and I am excited to introduce to you Robin Hacke, who is going to be giving a presentation today that we're recording, and we will have a subsequent conversation with Robin on June 5th. The title of the presentation is Investing in Health, Setting the Stage for Financing. This information is part of the Hacke Accelerator site financing web series that we're doing of a variety of different issues related to funding and financing population health. So a little bit about Robin. So Robin is the executive director and co-founder of the Center for Community Investment. She brings more than 2 decades of investment experience to the work, having served as the director of capital innovation for Living Cities, as a venture capitalist and strategy consultant in the technology industry, and as a public finance banker. Most recently, Robin was a senior fellow at the Kresge Foundation from 2014 to 16, where she researched and incubated a capital absorption practice to improve the ability of cities to attract and leverage capital for investment in public purposes and explore how philanthropy can develop strategies to advance this goal. She has served as a visiting scholar at the Federal Reserve Bank of San Francisco, a consultant to major foundations, and a member of the steering committee for the Federal Reserve Bank of Boston's Working Cities Challenge. And with that, I will turn it over to Robin.
Thanks, Sue. It's a pleasure to be here. The Center for Community Investment, which I founded about a year ago, works with communities to improve health equity by setting the stage for investment in affordable housing, access to fresh food, jobs, and other drivers of good health so that everyone has a fair chance to lead a productive life. We're going to talk today about what it takes at the community level to attract and deploy investment in ways that really make a difference for community health. And I look forward to having an open conversation about this material when we all talk in a few weeks. So as you all know, place matters to health. What we call the social determinants of health have a profound effect on health outcomes. And in the United States, those health outcomes are really not satisfactory. We see communities suffering from disinvestment, discrimination, and poor access to opportunities. And this is really inconsistent with our fundamental values as a people. Transforming those communities and those outcomes can't happen one grant or one program at a time. The scale of change that's required is much greater. It's really about system change and changes in the flows of capital, not one project or one deal at a time, but community scale change. In our system, the capitalist system, money naturally flows downhill to things that are easy and profitable and usually have been done before. What we want to talk about today is how we, through collaboration and through intentional efforts on improving equity, can get money to flow uphill to the people and places that need it most. The key to that is collaboration across sectors, across organizations, and in order to make common cause in that way, we need to be really clear about the outcomes we're trying to achieve, and that's what we're going to talk about a little bit more. But first, what I'd like to do is just spend a moment defining some terms. Investment in health can mean a lot of different things to different kinds of people. So let's just clarify for a moment, for the purposes of this presentation, what we're really saying. When we talk about funding, what we're really talking about is money that pays for spending. It can come from grants, from foundations or governments, but whoever is giving you the money doesn't expect to get it back. They may expect you, they will expect you, to use that money in a smart way to achieve important and worthwhile outcomes, but it's not money that you have to repay. On the other hand, what we call financing or investment is money that comes from people who do expect to be repaid over time. All of us are familiar with financing because buying a house with a mortgage or paying for college with student loans are examples of what we mean here by financing. Investors give you their money because they expect to get a return on that investment. And very often they expect to get back not only the original amount they gave you, the principal, they also expect to get more. That return can come in a lot of different forms. It might be interest, like on a loan, or it might be capital gains, like when you buy a stock and the price of the stock goes up, or it might be in the form of savings or avoided costs. For example, I may invest now in an intervention that has been shown to result in lower spending on juvenile justice or on hospital emergency rooms. That avoided cost can be a financial return as well. But in any case, repayment of that investment has to come from somewhere. And sometimes it comes directly from cash or cash flow that's produced by the investment. So for example, think about a toll road. You pay for building the road up front, and then every time a car goes on the road, the driver puts money in the slot, and that eventually pays back the cost of building the road. If you build a rental property or buy a building that's multifamily rental, you finance that with a mortgage, and the monthly rents that you get from the people who live in that building go to pay the mortgage. That goes back to the bank. So those are examples of repayment that comes directly from the investment. But sometimes there are investments that don't produce cash flows, like about a park. Think about a park. Those kinds of investments can be paid back through tax revenues. And the way that's generally done is through something called municipal bonds. We as citizens make decisions about how we want our tax dollars to be spent, usually by who we elect. And if we want sidewalks or parks or trees that don't generate cash flows, we pay for those things through our taxes. So there are all different kinds of repayments, direct and indirect. As impact investors are a special kind of investor, and they may be willing to trade off some financial return for the promise of social or environmental returns, things that they care about, like, for example, better health. We'll talk more about that in a moment and what that looks like, because impact investors are often the key to attracting money for the kinds of purposes that you're working on. But first, let's talk about the flavors of money. Money comes in different colors, even though it all looks green. If you're used to working with grants, you're probably living over there on the left side of the slide in the purple bubble. And on the spectrum of financial return, that kind of counts as zero, like there isn't any. So you may be producing important outcomes, and they may be satisfying the people who are giving you the money, but they're not getting their money back. Over on the right-hand side is the place where traditional financial investors like banks live. And they expect that if the market rate for investments right now is 5% or 8% or whatever it looks like based on how risky the investment is, that's how much they expect to get back from the investment. And in between is the full spectrum of the trade-offs that investors are willing to make, depending on how they balance financial return and the social impact that they're trying to achieve. All of these different kinds of money can be put to use to improve health outcomes, not just grants. So one more concept that I'd like to cover briefly is what we call capital stacks. Capital stacks are ways to blend together investors who have different tolerances for risk and expectations or needs for return. So if you think about, let's say, an affordable housing development that costs $10 million, you don't need $10 million in grants to pay for it. And that's what the power of a capital stack is. If you just used $10 million of grant money to buy your affordable housing, you can think of that as being like sheet cake. Every dollar that you put in of grant money will buy you a dollar of affordable housing. But if you think about capital stacks, you can use your $1 million or $2 million of grant money to reduce the risk or increase the return, or both, for investors who may have more traditional financial expectations. And so what you're doing is actually building the base of a layer cake, reducing the risk or increasing the return that other investors can achieve. And so if you think of using your $2 million to create a loss reserve or a subsidy, then you'll have an easier time attracting banks or other financial investors to come into your deal or project. That makes it look more like a layer cake. Doing that kind of stacking of capital, so the mix of risk and return that people take is coordinated, is what we call leverage. And if you think of this as a choice between, a pretty flat sheet cake where you get 1 for 1, or a layer cake that might give you 3 or 5 times as much money as you're providing into something you care about, it's pretty clear why you would want to use grant money in this way. You're leveraging your money with other people's money to get capital flowing in the direction of things that you care about, and that makes good sense. So one more clarification before we dive into what this kind of work looks like. There are a whole bunch of different ways to improve health outcomes and decrease health costs by using investment. What this matrix attempts to do is categorize what those approaches look like so that we can be a little clearer in thinking about our targets. Over on the left are what we would call the clinical interventions, and on the right are upstream or non-clinical interventions. Sometimes the line can be a little fuzzy. The rows differentiate the targets of the investment from people who are currently patients of the health system through people who are vulnerable and facing health risks and are likely to become patients, even though they're not at the moment, up to the whole level of the community or the total population that we may be trying to serve. So if you think about how we might improve health outcomes, putting a clinic in a school or in a public housing development would be what we would call box 3, expanding access. And that's a healthcare intervention outside of the hospital walls. And it does achieve broader access and probably better outcomes than what we're used to in regular clinical care. But it's not the kind of upstream intervention that we're primarily focused on. Things like investing in affordable housing or reducing air pollution or remediating mold in homes. And those kinds of non-clinical interventions, the blue ones, are what we're going to be primarily talking about for the rest of this presentation. So how can investment drive community health? What might those investments look like? Here we have a whole set of what the investments might be, arranged in a way that makes the ones that are easier to finance at the top, like affordable housing, to the ones at the bottom that don't produce cash flows, as we said before, like parks or green space. So if you think about rental housing, that we talked about a moment, if you have families living in that development, they pay rent. That allows you to repay investors, and that's pretty easy to finance. There are well-established models of how you do it. People know what interest rates to expect. They know how to evaluate the risk. It's maybe hard to find money that's willing to get a low enough return to have affordability, but the model of how to do that is pretty well established, and there's 50 years of history that demonstrate that it's not all that risky. If you think about an investment in the middle, like small business development, well, that's riskier because lots of businesses fail, or they might take longer than investors expect to produce profits. And so as opposed to housing development, where you have a tangible asset that you can touch and feel, small business development is a little squishier, a little riskier. And early childhood centers are even more difficult because the business model has to both attract children, find the facility, operate on a sustainable basis. It kind of mixes business financing and real estate financing. It's a little harder to do. The things at the bottom for which we really need, as we said before, taxes or programs funded by grants, really don't generate cash flow from the investment themselves. Why do we bother with this kind of spectrum? Just because it's important as you think about the kinds of interventions that you're looking to do, that you think about, are they really more about funding? Are they more about financing, or what's the mix? When we think about achieving investments for communities, what we found in our work is that there are really 3 functions that need to happen in a place for a community to be able to use capital to improve health outcomes. And these are the 3 functions that we see here. The first is what we call shared priorities. People have to agree in the place on what it is that they're trying to accomplish. And it has to be specific enough so that they can shape decision-making around what they prioritize. In other words, if somebody came to your community and said, we have $5 or $10 million to invest, and they asked, how would you use that money? You really all need to agree about what the most important and necessary purpose would be. And we'll talk more about each of these functions in a moment. The second function is the construction and execution of a pipeline of deals that adds up to what the community has prioritized. So if we've said it's all about affordable housing, we better have a set of affordable housing projects that would allow us to achieve our goals. And the third function is what we call the enabling environment. That consists of all the policies, practices, relationships that either promote or impede the execution of the pipeline. And all three of these things can be shaped and improved by a cross-sector collaborative effort. As the braid below suggests, it's not that you do these functions once and then you're done. It's actually that you work on all three of the functions at the same time. They interact, and you learn things through, let's say, working on the pipeline that will change your perspective on the enabling environment. Changing policy may change your priorities. They interact and go back and forth, and it's a continuous process. So let's take a deep dive into what each of those functions looks like. In the shared priorities function, we think it's really important to articulate a vision that on one hand is broad enough to be galvanizing and to matter to the community, but yet it's specific enough so that it can be used to shape decisions. Well, what do we mean by that? If you think about a kind of high altitude 30,000 foot view, we could say we want a city where everyone is better off, where everyone is healthy, but it doesn't have a lot of power in shaping investment because we're not clear about what better off means. Do we want more housing? Do we need more grocery stores? What is it that we're prioritizing? On the other hand, if we define the priority too specifically, like we are in a food desert and we really just want to build a grocery store, then we may not have a broad enough vision to mobilize all different kinds of stakeholders, including the ones that aren't usually included, and that makes it less likely that we'll succeed in addressing the issues. So sometimes we say you kind of have to enlarge the problem in order to solve it. What we see with shared priorities is that they may come from a formal process like a comprehensive plan or responding to a flood or natural disaster. And sometimes it's just a group of leaders coming together and saying, you know what, we together are going to do X. Any one of those processes is fine, but being able to articulate the priorities in a way that's clear and compelling makes a real difference. So the next function is the pipeline. There are a number of steps that are outlined here that can result in a group of projects that together have some power. The stages are laid out in a linear fashion, but that doesn't actually mean that they happen once and in the order that's shown here. There are very often loops that go back and forth between the stages. So what do we mean? In order to develop a pipeline, we have to start with somebody spotting an opportunity. They have to be able to say, here's where we think a housing development should go, or here's an opportunity to use an abandoned building to create a grocery store. Here's a place where we could turn a blighted property into parks. Somebody has to know the neighborhoods and the places well enough and the community's needs well enough to do that matchmaking and spot the opportunity. Somebody also has to go from the opportunity to turn something into an actual project with a developer and leaders and investors and banks. Somebody has to figure out what makes a particular project investable. How does it create the kind of paybacks that makes investment feasible? And somebody has to make sure that what we've ended up with in terms of the deal we're going to finance really accomplishes the vision that we set out in the first place. So those are the kinds of subtasks that are in the pipeline. When it comes to the enabling environment, the last function, we can shape the policies and priorities that we work on to make our deal pipeline move more smoothly. Sometimes it's about zoning policy or changing building codes or enforcing existing codes. Sometimes we decide to work on aligning our funding resources so that we don't work at cross purposes. It may mean focusing on whether we have all the skills in our community that we need in order to get projects built. Do we have the people who can spot the opportunities? Do we have the sources of capital we need to get our work done? It may also involve simple things like making sure that the members of the community are in regular enough touch so that they can talk about the issues of collaboration that are coming up from a financial perspective, from a development perspective, making sure that people have the data they need to build realistic business plans. All of those things are pieces of the enabling environment and can be worked on by a collaborative effort. When we look at the functions together, we see that they are what would allow us as a community to create and execute the kinds of investments that use financing to improve health. And it doesn't really matter specifically who does which function. What we've seen is that in different communities, the roles can be played by different actors, but we do need to make sure that every one of these jobs gets done. What we've laid out here are some of the typical ways that we have seen the work get done, but they are in fact not the only ways. And different communities have found that instead of having a bank play a certain role, it may be a nonprofit community development financial institution, or a community development corporation, or a community foundation. Sometimes business leaders step forward, or hospital leaders. We don't really care too much who's doing the specific roles as long as the work gets done. So when we look at the collaborations that we've seen across communities that are working on health, there are certain kinds of propositions that we see are in fact working over and over again. And so those are laid out here. The first is that big problems are not going to be solved by one single institution or type of actor alone. So whether it's a hospital or a community development corporation, no matter how well intended, that one actor alone is not really going to be able to make a system level difference. We think that collaborative approaches are in fact really critical to solving the kinds of problems that are wickedly complex and systemic. The second is that equity can't be an afterthought. It has to be intentionally at the center of what we're trying to accomplish. And we have to think about it every time we frame an intervention, every time we consider a change in policy. We have to make sure that what we're achieving is actually what we intended. We've seen too many examples of people working on amenities like parks or grocery stores in a neighborhood without making sure that they have locked down affordability in that neighborhood. So unintended consequences can really be an issue if we haven't put equity at the center. The third thing that we've seen is that there are no silver bullets in these challenges. Being adaptive and trying to understand what a situation calls for is really a more important way forward than just importing a model or a practice that looks elsewhere, that has worked elsewhere. So it's great to be inspired by models, but it's the getting people together in your place, in your community, that makes the difference. Shifting business as usual, also a crucial thing. As you introduce innovations and different practices, it's really important to think about what can be sustained over time. If you just incrementally look a little bit different, it's not going to get you there. Divergent perspectives also really important, especially the voices of the people that you're trying to benefit, because otherwise the likelihood that you hit it right is going to be much less. And finally, as we have suggested from the beginning, capital matters. If you're going to get to a scale that is transformational, just working on grants alone is unlikely to get you there. Really thinking about what kinds of projects can be financed with capital, how grants can be used in a capital stack makes a big difference. And then we've seen that there are some pitfalls that partnerships tend to encounter when they try to do investment for health equity. So here are some of the things that we think are worth thinking about. One is to be clear about the result. You can't do everything, and you can't do everything at the same time. So setting a clear result and a clear focus for what you're going to do first is important. Peanut butter and spreading it around is really not that effective. The second is to make sure that you have the right partners at the table, not just the ones you know, and not just maybe the obvious ones, but the ones whose direct contributions are required to achieve the result that you're targeting. So if you're not talking to hospitals, if you're not talking to community development corporations and CDFIs, then reach out and involve them in your effort. Make sure that your strategies are in line with the scale of your ambition. If you're shooting for population level impact, don't just look at one program, look at how you can do a whole array of activities, investments, and programs to get to your result. And then the last is, don't wait to act. We've seen an awful lot of planning that doesn't lead to action. Nothing is going to be perfect, but we have seen in our experience that getting moving, starting to change, and learning as you go is really the most important part of making an effort like this successful. We've written a paper about how health institutions can get involved in strengthening community investment. That's available on our website. It gives plenty of examples of how community partnerships have worked with hospitals and health systems to achieve health equity objectives. And I'm happy to answer any questions that you may have in the upcoming webinar or by email. So we ask that you get in touch with us, and we wish you luck on your important journey. Thank you very much.
Thank you so much, Robin. We look forward to the discussion that we'll be having on June 5th. Thank you.